Hello and greetings. My name is Kashaylin Hollins-Henderson. I am a board-certified gynecologist and reproductive specialist. I currently practice in the THR Infertility Clinic in Plano, Texas. My role at the clinic is to help couples who desire to have children conceive through various methods once a cause has been determined. Infertility is a very common occurrence seen in the practice of gynecology. Experiencing infertility can be very emotional for the couple, especially the woman, and needs to be handled in a very sensitive and discreet manner. Let me give you some statistics about infertility. The etiology of infertility can be identified in 85 to 90% of couples, being 30% have male factor infertility, 35% have female factor infertility, and 20% have a combination of male and female factor infertility. Some of the common causes of infertility are polycystic ovarian syndrome, endometriosis, gliomas, carcinoma in situ, chlamydia, genital herpes, gonorrhea, syphilis, trichomonas, smoking, alcohol, and many other contributing factors. Infertility is generally defined as 1 year of unprotected, frequent intercourse without obtaining conception. The disorder that I frequently come across in practice that causes infertility is endometriosis, which is a major cause of infertility. Endometriosis is a condition in which endometrial tissue, glands, and stroma are located outside the uterine cavity. The fertility is impaired by mechanical factors interfering with ovum pickup and tubal transport, by ovulatory dysfunction, and by interference with sperm function, fertilization, and implantation. Endometriosis occurs in 6 to 10% of women of reproductive age, with 38% being affected, and 71 to 87% of women with chronic pelvic pain. The actual prevalence is difficult to determine because of the difficulty to diagnose endometriosis. Common symptoms of endometriosis are dysmenorrhea, chronic pelvic pain, and dyspareunia, and others are even asymptomatic. To date, the definitive gold standard test is to diagnose endometriosis by direct visualization of classical or subtle lesions at the time of laparoscopy and laparoscopy, and the histology of lesions removed during surgery. The treatment for endometriosis is determined by the severity of symptoms, the desire for fertility, the degree of disease, and the client's therapeutic goals. For women who want to maintain their fertility potential, medication and conservative surgery should be the choice of treatment alone or in combination. Definitive surgery is indicated for women with the failed medication treatment and have no desire for future fertility. Definitive surgery will consist of hysterectomy, bilateral oophorectomy, and removal of all endometriotic plants. The treatment length determines how long the client wants to maintain fertility, manage symptoms, or fertility is no longer desired. Let's talk about a patient that we did a case study on. KC is a 29-year-old African-American female with endometriosis. Otherwise, obstetric and gynecology past histories are unremarkable. Patient is married, non-smoker, and a homemaker. No surgical history and no known drug allergies. A review of all systems reveals no obvious abnormalities. Menstrual history as follows. Menstrual period occurs irregular with severe pelvic cramping and pain. Last menstrual period was 1 month ago with irregular periods, heavy bleeding, and is not taking any oral contraceptives. Patient is Gravida 1, Power 1, delivery without any complications. No birth control methods used in the past other than condoms. Endometriosis confirmed by laparoscopic procedure 3 months ago, and symptoms has worsened. Patient is now returning to the clinic to discuss and start treatment options. Patient prefers to start with the least conservative measure. Plan for today is to start KC on meloxicam 50 milligram BID, which is an NSAID analgesic, and a combined oral contraceptive, norethindrone acetate, and take 1 tablet daily following the pack instructions. Patient is instructed to return to clinic if signs and symptoms worsen or if there's a new onset of problems, questions, or concern. Patient is to follow up in clinic 3 months for evaluation of current therapy. Patient verbalized understanding. A healthcare provider needs to be familiar with the diagnosis, management, and follow-up of common gynecologic pelvic disorders encountered in practice, like endometriosis, and must recognize when a client should be referred for further evaluation and treatment. Endometriosis is a very common gynecologic disorder that is very difficult to diagnose. It's important for us to understand appropriate follow-up intervals depending on the choice of therapy and the client's need. It's always okay to consult a gynecologist for more specialized treatment. In my opinion, I don't feel there are any major problems that need to be solved in the referring to endometriosis.